take up the next talk for the session, and I shall be discussing on the renewed interest of glycerol preserved donor corneas for penetrating keratoplasty in emergency situations. So I hope my slides are visible.
Yes, yes, sir.
Okay, great. Thank you. Thank you. So, so we have no disclosures. The glycerol preservation of corneal tissue is has been in vogue since half a century, almost from the 1955-60s onwards. But it has always fallen aside because the process of glycerol preservation has rendered the corneal tissue non-viable, but the tissues can be stored indefinitely. There was a renewed interest in glycerol corneal preservation in the COVID era. This is because world over eye banking systems were collapsing in the wake of the rapid rise of the pandemic, the surge of cases, and thereby the consequence on decrease of corneal retrieval because of COVID. So when we reviewed the existing literature, we found that glycerol corneal preservation is a very easy to perform procedure. It can be used by any eye bank, and it doesn't require a lot of equipment, and the storage is fairly simple from room temperature to minus 80 degrees almost. And these provide a source of corneas for emergency and tectonic purposes, such as tectonic or therapeutic penetrating keratoplasty. The drawbacks of this technique are that the corneas tend to be acellular and therefore they lose their clarity over a period of time. But the corneas that are preserved in glycerol tend to have excellent clarity during the process of preservation, and they gradually become opaque. So if we see this IOVS paper from 2012, the top two pictures show corneas that have been preserved in glycerol at minus 20 and minus 78 degrees compared to those in the bottom where they have been preserved with silica gels or without silica gels at room temperature. So initially they are clear to start with, and they are typically preserved in vials of 20 ml of sterile glycerol, which is 99% pure, and they need to be thawed by thoroughly washing with BSS and then allowing it to hydrate over a period of 10 minutes before preparing them for transplantation. This was a clinical case of a corneal melt which very rapidly progressed to a 6 mm central corneal perforation. A glycerol cornea was used because this case was performed during the pandemic and fresh tissue was not available. A freehand dissection was performed after marking the cornea, and once the trephination is done, the glycerol corneal tissue which has been thawed was used. So as you can see at the beginning of the surgery, glycerol corneal tissues tend to be fairly clear, and it allows somewhat good visualization of the anterior segment. However, the tissue tends to swell up during the surgery and it becomes opaque, and suturing also is a bit difficult because these tissues are stiff and they may not be very pliable. So this was the surgery that was being done, and a flanger ring was used because it was a large corneal perforation, and the procedure was completed with 16 interrupted sutures. The post-operative outcome was uneventful, and at 4 weeks, the graft had taken up well, it has started to fail, and there is also a good epithelialization, and the posterior segment was normal with retina on. This was another case where, again, similarly, glycerol corneal tissues were used, donors were used, and it resolved uneventfully except for intumescent cataract, which necessitated extracapsular cataract extraction. And at 4 weeks, the graft was beginning to fail, but the posterior segment was essentially normal. So these cases could be taken up for subsequent management in terms of the optical keratoplasty once the graft has taken up. So the eye could be salvaged in such cases. This was again a similar case of extensive fungal keratitis necessitating treatment with glycerol preserved corneas. There is also a drawback of these tissues. The epithelialization is extremely slow, and in this case, typically, this is the epithelial defect at 1 week, and again, it at 2 weeks, and almost at, at 5 weeks, the epithelial defect still persists. The epithelialization is extremely delayed, and often these persistent epithelial defects, unless addressed by a concomitant tarsography, might lead to melt in the graft. When we compared the outcomes of glycerol preserved corneal tissue in our study, which is currently under review, with a paper that has also been published in IJO by Gupta et al., we found that the very common post-operative or perioperative complications are either a recurrence in the graft, delayed epithelialization, and glaucoma. All in all, there are certain interesting surgical tips that we picked up along the way are that it needs adequate hydration and thawing before using a glycerol preserved cornea. A sharp trephination is desirable. The tissue tends to opacify as the surgery progresses, and suturing is difficult, and sometimes that's the reason why the surgery can be a bit prolonged. Tarsography certainly will be advisable because the tissues have a very slow rate of epithelialization. Apart from that, these tissues do very well tectonically, and they can also be taken up for lamellar transplants. Thank you very much for a patient hearing, and I would like to take this opportunity to thank the scientific committee and Dr. Somshila Murthy for this excellent session on corneal tips and tricks. Thank you very much.